All right, everyone, welcome. Today, we're going to tackle a classic clinical finding, the enlarged liver. Whether you've actually felt one on an exam or just seen it flagged on an imaging report, knowing how to approach hepatomegaly is an absolutely core skill. So let's build a really practical, systematic approach together. So picture this. You're on rounds, you just finished examining a patient's abdomen. Your attending turns to you and asks that exact question. Now, this isn't about just a simple yes or no. It's about having a plan, a whole system ready to go. This explainer is going to be your guide to building that approach, step by step. So here's the game plan. First, we'll define what we're even looking for. Then we'll get hands-on with the physical exam itself. After that, we'll build a really powerful differential diagnosis based on one single key finding. And finally, we'll walk through a super clear diagnostic workflow, taking you from that initial suspicion all the way to action. Okay, first things first. What even counts as enlarged? Because, before we can even start to identify what's abnormal, we have to be absolutely rock solid on what's normal. Well, simply put, hepatomegaly is just a liver that's bigger than it should be. But I want you to notice that key word there, suspected. Your initial exam or that incidental finding on a scan, that's just the starting line of your investigation. So let's talk numbers, because this is crucial. Now, it definitely varies a bit with sex and body size, but the general upper limit of normal for a liver span on ultrasound is less than 16 centimeters, right, in that mid-clavicular line. If you see a number bigger than that pop up on a report, your hepatomegaly alarm should be going off. Now, this is a super important point. Not every liver you can feel is actually an enlarged liver. You have to be aware of the mimics. A Riedel's lobe is the classic example. It's this totally benign, tongue-like projection of the right lobe that can feel huge. Or think about a patient with severe COPD. Their diaphragm literally pushes a normal-sized liver down, making it easy to feel below the ribs. So you've always got to keep these anatomic variations in the back of your mind. Okay, let's move to the bedside. A good physical exam is your absolute best initial tool, not just for suspecting hepatomegaly, but for starting to figure out its character. All right, percussion. This is all about mapping out the boundaries. You start way up high on the chest where it's all resonant from the lungs, and you percuss your way down until you hear that dull thud of the solid liver. Boom, that's your upper border. Then you go down to the belly, find a nice tympanic gassy spot, and percuss up until that sound turns dull again. That's your lower border. And the distance between those 2 points, that's your estimated liver span. So once you've percussed that lower border, it's time to palpate. You're going to place your hand just below that spot and have the patient take a slow, deep breath in. As their diaphragm pushes the liver down, you want to feel that edge just kind of roll under your fingertips. And this isn't just about size, it's about what it feels like. Is it tender to the touch? That screams acute inflammation. Is it firm, kind of lumpy and nodular? That gets you thinking about more chronic stuff like cirrhosis or even malignancy. Okay, so you've done your exam, and you're pretty sure you found hepatomegaly. Now for the single most important question you can ask at the bedside. Is it tender? Because this simple distinction is the absolute key to organizing that huge list of possible causes. This right here is your money slide. Tenderness suggests something acute and angry is going on. Think rapid inflammation or sudden congestion that's stretching the liver capsule and causing pain. On the flip side, no tenderness suggests a chronic and quiet process, something that's been slowly building up or infiltrating over a long time. This one branching point makes a massive, intimidating list of causes so much more manageable. So let's look at that acute and angry category first. For acute hepatitis, you're thinking about things like viruses, certain medications, or alcohol causing really fast inflammation. For impaired venous outflow, you're thinking about a plumbing problem, right? Like a clog in the drain, which is basically what Budd-Chiari syndrome is, or a backup from right-sided heart failure. Both of these just congest the liver with blood, making it swell up and become really painful. Now for the chronic and quiet stuff. You've got storage disorders where the liver cells themselves are just getting filled with, well, stuff, like fat in steatosis or iron in hemochromatosis. Then you have infiltrative diseases. This is when other cells or substances are actually moving into the liver, like amyloid protein or granulomas in sarcoidosis or even cancer cells. Because the process is so slow, the liver just gets bigger and bigger without that acute pain. And we're still on the non-tender side. We've also got cholestatic diseases like PBC and PSC. This is where the flow of bile gets messed up, leading to chronic inflammation and enlargement over time. And hey, don't forget other structural causes like polycystic liver disease, where the liver is slowly getting replaced by cysts, or even really large benign lesions like hemangiomas. So, with our differential diagnosis all mapped out, let's build a practical workflow. This is your game plan, how you take that initial finding and methodically turn it into an actual diagnosis. This is your 4-part initial workup. First, you start with a great history. You've got to ask about alcohol, medications, any systemic symptoms like fever or weight loss. Then a really focused exam, looking for things like spider nevi, ascites, or maybe an elevated JVP. Step 3 is your initial labs, your standard liver panel. And finally, a Doppler ultrasound is absolutely essential. It confirms the size, looks at the liver texture, and crucially, it assesses the blood flow going in and out. Okay, after that initial workup, everything, and I mean everything, hinges on this next question. The results of those liver tests are going to dictate your entire next move. So if the labs come back abnormal, you follow the pattern. A hepatocellular pattern with those high AST and ALT levels sends you down the path of investigating hepatitis. A cholestatic pattern with a high ALK phos points you toward issues with the biliary tract. Each pattern has its own specific workup, which is a whole other topic, but just recognizing the pattern is the key first step. But what if the labs are normal? If imaging confirms the liver is truly enlarged, but that basic liver panel looks totally fine, you need to start thinking bigger. This is where you really have to hunt for those infiltrative or storage disorders. Unexplained fatigue and weight loss in this setting, for example, should make you really consider something systemic like amyloidosis. And this is a really, really important point to remember. If you thought you felt an enlarged liver, but the labs come back normal and a formal ultrasound shows a normal-sized liver, you can generally stop. Your exam was likely just fooled by one of those anatomic variations we talked about earlier. It is absolutely okay to stand down. So, we've covered the standard workup, but let's end this with the most critical question of all. When do you stop investigating and start calling for help? Like right now. When does this finding signal a true emergency? These are your red flags. If your patient has signs of acute liver failure, I'm talking new confusion or a rising INR, that's an immediate consult. Same goes for new signs of advanced chronic disease, like ascites. If you even suspect a complex vascular issue, like Budd-Chiari, or if the patient just has this persistent pain and an enlarged liver that you can't explain, don't hesitate. Pick up the phone. Honestly, knowing when to call for backup is just as important as knowing the workup itself.